So VCTE, vibration-controlled transient elastography, is a way of using sound waves to see how much fat is in the liver and how much fibrosis in the liver. So we want to find that early so we can intervene in reverse with GLP-1, diet, et cetera, before the liver passes that river Styx and you wind up with people with cirrhosis. And there's no question that this group of tools is going to allow us to find people in their 30s and 40s where their liver function tests, their transaminases are mildly elevated. People have been poo-pooing it for a while because they're not jaundiced and they otherwise feel well. Well, that mild inflammation is like rust on your car until your entire exhaust system goes out in your 50s and 60s.
Today, we had a great time speaking with gastroenterologist and chief medical advisor, Dr. Alan Epstein, as we talked about gut health and its relationship to overall health, food sensitivity, EoE, and many other topics, including ancient feces and what it tells us about the current state of the gut microbiome. All that and more on today's episode of My Allergist Dad.
Throat tickle or itchy eye, skin rash or a patch of hives. If allergies got you down bad, then just ask my allergist dad.
Welcome to My Allergist Dad. I'm Drew, and I'm here as always with my dad, perennial top doc for allergy and immunology in Rhode Island, Dr. Z. Hey, Dad.
Hey, Drew.
Hey, so today we are very excited to welcome onto the show Dr. Alan Epstein. He served as the director of gastroenterology at Roger Williams Medical Center for 32 years. He's a graduate of the Boston University School of Medicine. As we know, it's the Chobanian and Avedisian School of Medicine, we've discussed many times. He did his residency and fellowship training at Beth Israel Hospital in Boston. Dr. Epstein practices gastroenterology for Open Door Health and currently serves as chief medical advisor for GI strategy at GistMD, which is focused on improving patient understanding and care delivery through clinically grounded digital tools. Dr. Alan Epstein, welcome to the show.
I'm just delighted to be here. I think I've known John for 30, 40 years and had the pleasure of working with him in Providence, and it's just a pleasure to be on the show, and especially to talk about everywhere where we overlap between the gut and allergy and the microbiome and all the interesting non-procedural things in gastroenterology.
Besides the fact you have one of the smartest guys in my med school class on here. He can talk about anything, and this is going to be great.
Yeah, my dad speaks very highly of you, so it's great to put a face to the name.
Well, I think we've been very lucky to be able to work together for so many years, where people tend to live in their own silos in medicine. And I think that's what's bad about medicine is, no matter what topic I'm dealing with in medicine, I'm always thinking about, well, if I'm talking about fatty liver disease, I'm really talking about cardiometabolic renal disease as well. And so it's taking a broader, your dad and I were, internists way before we were subspecialists. And as long as we keep going back to that, we can work much more effectively together.
It's interesting you said that, Alan, because I like to look at the positive. So I'm reviewing articles for my maintenance of certification I do every 6 months. And one of the things that came up was they spoke about the causes of chronic cough. And reflux, GI, was one of them. Obesity is one of them. And when it came to especially adult onset asthma, a lot of the times the biggest risk factors is less allergy and more metabolic syndrome, obesity with cough. And you're right. I find that patients, they'll come, and I've brought this up in the podcast before, they'll be coming to see me, and as they're leaving, they'll say, well, I'm seeing GI, pulmonary, dermatology, et cetera, all in 1 week, which sounds good to them, but it really hinders looking at the bigger picture because now you're not communicating as a team. And it makes it harder for the patient, harder to change things, harder to address new things when someone else might be addressing it. It restricts you. And I think it's getting harder for everybody.
It's
Well,
like
yeah,
that what is it, that story with the four blind men all touching the elephant and
Yeah.
everybody's
absolutely.
feeling a
That's
different
a
thing and
perfect
thinks it's a
perfect
different thing.
metaphor for that is everyone's dealing in their own little silo and not really addressing the whole problem, nor do people communicate the way your dad and I used to,
Yeah.
which is we would talk to each other. I'd say, hey, you're going to see this patient, and I'm very concerned about X allergic thing. So you're going to work that up, and I'm going to work this up, and this is how we're going to pull ourselves back together. But it didn't then branch out into 15 other specialists and 20 other visits and 15 other medications for the patient.
It's
So I
less
think,
and less happening, which is making it harder and harder.
right.
And then every time I have someone who communicates, they're leaving the state. It's like,
Yeah.
oh my God,
Right. I
it's
mean,
crazy.
I realize that I'm gray haired, but like I will sometimes finish my session at Open Door and call a provider, and they're like, you saw the patient today and you're calling me? And I was like, yes, because I want you to know what's going on, as if
Yes,
that was some kind of miracle that
I
happened,
know, it's crazy.
yeah, it's crazy.
And we spoke about the topic today and having Alan and why it's on the rise so much and what's going on with EoE.
Yeah, we wanted to hear your definition of eosinophilic esophagitis, or EoE as we'll refer to it in shorthand and save us time in syllables.
It's interesting. When I finished my training, when dinosaurs were walking the earth, this was not a disease that existed.
And just to add to it, because I've said this to Drew and my patients, this was something that you learned about for your boards when I started. And I never saw a case. And now it's very common.
And by the time I finished, there wasn't a week that went by where I wasn't having that, at least in my differential diagnosis, or finding it. I would be called at night to come do a foreign body in the esophagus. Someone who swallowed something, didn't go down. I'd have to go fetch it out. And it wasn't from the classic reflux and stricturing, the heartburn causing scarring of the esophagus. I would see this furrowing of the esophagus and the classic look of EoE. And I'd say, oh, this is, a 25-year-old who didn't have heartburn. All of a sudden, he's got a piece of steak stuck in his esophagus. He has EoE. So exactly what the triggers are interesting, because we're not really sure. It's not like you're allergic to one thing. So in the this is very important in the pediatric population, where the pediatricians start doing things like these 6-food elimination diets, where they're getting rid of milk and wheat and eggs and legumes and peanuts, and fish and shellfish. And it's very restrictive. And then you gradually add foods back to try to make people better. Fortunately for us in GI, about half the people or more will respond just to acid suppressive therapy. So if you use proton pump inhibitors and you quiet the acid down, that seems to be a secondary driver for at least half the cases. You can make people better with very conventional medications.
So what would those be? Would that be like Pepto or?
No, those are things like Prilosec and Prevacid, omeprazole, lansoprazole, all of those drugs. So they're extremely effective in treating about half of our adult patients. And when that doesn't work, you can play around at great depth with the food elimination diets, or what I would often do is refer to your dad to say, let's see if we can hone in on something, because honestly, when you have to do elimination diets on people, it's a huge nuisance in their day-to-day lives.
What I found interesting is I'm seeing different groups of patients. I don't see many of the pediatric ones because Hasbro's has their own clinic, which may actually not be great for them, because one of the things that I read an article that, and I'm not sure, because a lot of allergists have problems with this, because there's been some association with IgG4. And some people believe in it, some don't, because it's a marker of desensitization. But what's interesting about that is we do the sublingual immunotherapy and we do oral desensitization. And one of the risk factors of oral desensitization, sublingual immunotherapy, is EoE. And a measure of success of the desensitization is elevated IgG4. So they show that with children, studies have demonstrated an association with milk, which seems to be one of the main triggers, and elevated IgG4. I do a food sensitivity test that's been reproducible.
Is that KBMO?
Yes, the KBMO one. It's not standardized, but it really has had great reproducibility with my patients. So often when they don't want to do an elimination diet, that test helps focus on the key ones for them to do, especially because it's often gluten, dairy, and eggs.
Eosinophilic esophagitis, is that, food sensitivity borne throat inflammation? Like, what exactly is it?
It's esophageal inflammation. So the esophagus is got a very smooth lining, and when it gets inflammatory cells in the mucosa of the esophagus, which is predominated by eosinophils, the way we make the diagnosis is that when we endoscope people, we biopsy up high where it's away from the reflux area, and we see a significant eosinophilic infiltration greater than 15 eosinophils per high power field. So as we look at the slides, we see an invasion of allergic type cells, and our pathologist can make the diagnosis for us. And then we're, at least as gastroenterologists, we're almost always going to start acid suppressive therapy, which helps for reasons that are somewhat obscure. But maybe you need a bit of acid irritation to start to trigger this process, although it's probably not the prime mover compared to regular reflux.
But I've been wanting to ask you this question, and again, I always look at the positive of my maintenance of certification tests. So
As annoying as they are,
they're positive. And having read an article today, it brought up two thoughts. These are a few things I want your comments on, but let me start with it. So the first thing is, I find it's very similar. If you think about it, it's all one airway it's like from the sinuses all the way down to the lungs, and then taking a right or a left into the whole GI tract. It's all like one open area. And more they show that all the way into the alveoli, your lungs are not sterile. Your bronchi are not sterile. There's a microbiome there. There's even a brain microbiome. And then we'll go into the ancient poop later, and that might be playing a role too. But I seem to see from you guys two types of patients. And it's very interesting to me, the similarities between EoE, like someone who really has that inflammatory pattern you speak about, and the remodeling you see in asthma. So when you see an airway in asthma, that really where you get these patients, and I often used to say they're in their 40s and 50s, now I say they're in 60s and 70s, who may have had not as aggressively treated asthma, but they have irreversible obstruction. They have thickening of the basement membranes. They have this mucosal thickening, and then they have EOS, and it's like and a fibrotic appearance, and so in a lot of ways, even though we see environmental allergens as a trigger, I noticed once someone was doing a gut test, and there were dust mites in the gut. And it's funny how there's such a similarity. And also, I saw a guy the other day, and I see this a lot, including my elder son, where they had really bad allergies. They had some atopic dermatitis, they have food allergies. And then as they get into their 20s, and they're starting to have EoE. And so these really atopic, often more, because as kids, it's male more than female. And then it seems as they're going along, now they're getting EoE. And then at the same time, I'm seeing older patients without really an atopic background, more female, they did a study on asthma, and they showed that older asthmatics are more female, less atopic, have more metabolic syndrome. So it's more this inflammatory situation. A lot have fatty liver, which you brought up. And then the final thing that was interesting regarding that acid suppression, I just thought of, one of the things that I was taught as an allergist to do with people with chronic cough is to do an upper laryngoscopy. There's a characteristic in redness of the vocal cords. But what they said in the article is they're not sure they encourage that, because they showed acute swelling of the arytenoids and inflammation occurring with cough, which might be induced by GERD, but it's just, so it's all related, but they show it's right away. And then there's the GERD-induced cough, and then the GERD-induced inflammation of that airway. So it's all interrelated.
My daughter's a pediatrician, so I really should have had her on with us today as well. We could have, because I'm sure
Well,
she deals
if she's
a lot.
open, we'd love to have her on at some point.
Yeah,
And
definitely.
you can come on too.
Yeah,
Again.
I think that would be a lot of fun, but she's not allowed to bash me too much while I'm on, roll her eyes while I'm talking.
We'll have our producer edit any of that out as needed in post.
Yeah. That's what they did with the wedding picture with my sister-in-law or something. She was looking a different way.
there
My
you go.
mother-in-law didn't like it, and she had different eyes put in the wedding pictures.
But I think, we're good at treating EoE when we use strong acid suppression. We certainly use topical steroids. So we use budesonide, these quickly metabolized through the liver steroids that aren't dangerous, swallowed, or we'll have people spray the asthma inhalers in their mouth and not inhale it, but spray and swallow that. So we're good with topical steroids. And of course, if you really want to, there's a small percentage of people for whom we'll use the monoclonal antibody dupilumab, which I know you probably prescribe like crazy.
I don't. That's
You
the
don't.
funny thing is because I'm into the root cause.
Right.
I am so much less into doing it. They play a great role.
Right.
And unfortunately, it seems like more and more people are going straight to them. I mean, I have people, I have EoE. Should I go on Dupixent because it's advertised?
Right.
I'm like, oh my God.
Right.
And,
Well,
and
to
there's
me,
a
that's
definite
third
role
place.
for it. They
Right.
work
To me, that's the
fantastic.
third place where you wind up.
Yes.
Which is, acid suppression plus topical or swallowed steroids, and then third to get to Dupixent, to dupilumab. But a lot of patients will come to me having the diagnosis, but someone started them on dupilumab.
Correct.
So
It's happening with eczema.
So I have a couple questions then. So is EoE always born out of food sensitivity or some kind of like inflammation from that kind of reaction?
It's triggered by something, but in some cases it's food, and in some cases it may be environmental or from molds and things. We don't know every trigger to it. We know what we see when we do the biopsies.
Yeah.
But for me to say for an individual patient, walk back and start with 6-food elimination, go do allergy testing, it's a bit difficult to work backwards like that. So we tend to treat and make people better. But, you would like to get to the root cause and say, well, I really know that I need to get rid of shellfish. And if I get rid of shellfish, I'll be better. And then I won't be on dupilumab. I won't be needing to play around with my asthma inhaler and swallow the steroids, whatever.
A lot don't want to be as aggressive with the diet. It sounds
Yeah.
good.
Plus.
Sounds simple, but some don't.
Right.
And
With the ones who do, have you found any sort of like particular success rate, or is it variable because it's not always diet?
Well, yeah, it's not always diet, and it's hard in adults. I think kids do better because parents tend to control their diet more. So I think the pediatric gastroenterologists do a better job with food elimination things, and they can see it as food. You can either eliminate all those things and gradually add them back and see where symptoms recur, or eliminate one at a time over a month or so and try to walk through that. Then people will start often with just milk and wheat. There's 2 food eliminations. There's a 4 milk, wheat, eggs, soy, legumes.
But you see a difference with kids and adults because I always read that it was like 80% of kids it's foods, and then with adults it's something different. I truly feel it's like all these things happening, that EoE is just one of the factor of some sort of inflammatory response going on. And, as we learned in med school way back, before people even acknowledged it, there seemed to be these genetic markers or genetic factors, and then something in environment just turns it on. And I think we're seeing it more and more, that there's stuff that go through the generations. Everything is happening at once and you see it, but I'm seeing it in the very atopic, like the ones that have such high IgE, EOs, topical this.
It's something beyond food, or just natural foods, because, if I go back, I never saw this in the 1990s. So it's this I've seen since the millennium.
Food allergies up too. I mean, all these things, but even look at your conditions that you treat that are autoimmune. I mean, I don't remember ulcerative colitis and Crohn's and psoriasis and all this stuff being as prevalent as they are now.
Certainly, there is more. We're better at diagnosing it, so that's part of it, and better at categorizing it. But seeing more inflammatory bowel disease.
Have you noticed more celiac disease?
I don't know about more celiac disease, but more people that think they have celiac disease. So, because it's in the media so much, and social media has people thinking that, wheat is bad and gluten, and there's this drumbeat of anti-gluten. For me to make the diagnosis is pretty straightforward, and how to intervene is straightforward in terms of celiac. So it's not so much a rising incidence as patients who believe they have some kind of wheat sensitivity, and there is that. There are people who seem to have non-celiac wheat sensitivity. Wheat is funny because it entered the human diet relatively late, only about 10,000 years ago. So you don't see it in societies that are corn-based or oat-based and things like that. So making the diagnosis on blood testing with tissue transglutaminase antibodies and endomysial antibodies, and looking at HLAs when you have to, that's pretty straightforward. In the pediatric world, if your blood tests are high enough, they don't even endoscope anymore, then you just have celiac. In the adult world, we still biopsy people to see that the nice villi are blunted, and that you've got this inflammatory infiltrate down at the base of the mucosa. So celiac is its own thing, which is which is stable, but people who feel that being off wheat makes them better, I think that's a hard thing to bring out in clinical trials and whatnot, because there's a huge placebo effect saying, like, I eliminated wheat and I'm feeling better. Well, for a lot of those people, they eliminate wheat and pasta and things, they lose a little weight and they do feel better because they're a little bit healthier, kind of thing. I think we don't have any kind of good blood tests for wheat sensitivity, for non-allergic, non-celiac wheat sensitivity, but we have excellent testing for celiac, so celiac should be straightforward.
So you mentioned, wheat-based societies, there's a lot of wheat sensitivity or celiac. Is there much literature, or have you seen much about, you mentioned corn and oat-based societies where they're having corn and oat sensitivities? Or, is there a celiac disease for something like corn?
Just allergies, but people in those societies really, they tend to be, if you look at Mexico, corn-based society, you don't have any corn sensitivities. I imagine there's rare corn allergies and things like that, but it's not as allergenic a grain as wheat is.
Do you know if they're as genetically modified or something, or processed?
That I don't know.
Yeah.
I don't know.
Because a lot of people find that in Europe, they tolerate it, but not here.
Yeah, I'm actually going to be doing a study of one person on my honeymoon in Italy, whereas someone who has tested for gluten sensitivity, I'm going to see how I feel eating a lot of gluten in Europe, and I'll report my findings.
There's no question that the pastas that are made in Italy are made somewhat differently, and the way the wheat is processed is somewhat different. So people who feel that they're wheat sensitive may tolerate those better, not because it's celiac related, but because of the way the pasta is processed.
Do you know any places that might reimburse me if I do anecdotal data collection?
Maybe the pasta industry.
Okay, yeah.
If you went to the people who make the pastas that are imported from Italy, say, hey, I'd like to do this study, and get Americans eating, less ronzoni and less Prince spaghetti and more whatever Barilla or whatever's coming from Italy, that kind of thing.
I'll look into it. I can't remember. I think it's even in LA, but it might be New York, a place that daily flies their pasta in from Italy.
Someone's doing things like that, in every foodstuff. I mean, it's like thinking that bagels are because of the New York water.
So, Alan, one
Yep.
question I always wondered, and I just want to know how it plays a role with any of this. When we were in school, people were in endoscopy was all a barium swallow.
Right.
How much, and they used to talk about Shotsky's, or in our class, it was that other guy, because he was
Right.
from BU,
Yeah.
his ring. And how much of that plays a role with because like my brother got bougied,
Wait, bougie, like bad and bougie?
my brother had food stock.
Right. So the issue is, before we had fiber optic endoscopy, and before it was so routine, and we get histology everywhere now, in barium swallows, you don't know what causes the stricture, and it's not sensitive enough, except for you to bring out an EoE related stricture versus a GERD related stricture. So that's the benefit of fiber optics. That's why a lot less barium studies are done these days.
But do you think that's part of the reason we're seeing it more?
No, I don't think that's the reason. I think there's definitely a higher incidence of it, and exactly why, I don't know. It's not because we're better equipped to make the diagnosis. I mean, here and there, yeah, but I mean, we've been doing endoscopy aggressively since around 1995, early 1990s, and you didn't really see the EoE thing bubble up until the early mid 2000s.
One of our guests showed a correlation. He did a study, and Dr. Tano, he was on the podcast, and he speaks about endocrine disruption. And he looked at CDC reports dating back to the 80s, and he looked at the obesity epidemic. And what he showed was, like in the 80s, maybe it had been 14, 15% of the population. And much of it was concentrated along the Mississippi River into the south. And his theory about peanut allergy is more where the Israelis entered early, is that the Israelis had less because they got their peanuts from Argentina and not Georgia. And then he shows that it's spread out in the country following agriculture and pesticides and GMO. And he just shows, because of what's showing it, the CDC, et cetera, and this whole thing of correlating with obesity. And when they did the chronic cough today, asthma, they were talking about adult asthma, looking at people with mild asthma with exacerbations. And one of the questions is, what's one of the biggest risk factors? And it was obesity. And obesity is associated with adult asthma. Obesity is associated with inflammation. Obesity is associated with fatty liver. And all these things, if you think about it, when you have a fatty liver, you're not processing toxins as well. Your detox goes down, and these things are going around in your body, which is stimulating the immune system.
So what's nice is part of what I brought to Open Door was we brought vibration controlled transient elastography. People call it fiber scanning, but there are many competitors in the market to really look.
Can you say that again in English?
Oh, yeah. So VCTE, vibration controlled transient elastography, is a way of using sound waves to see how much fat is in the liver and how much fibrosis in the liver. So we want to find that early so we can intervene in reverse with GLP-1, diet, et cetera, before the liver passes that river Styx and you wind up with people with cirrhosis. And there's no question that this group of tools is going to allow us to find people in their 30s and 40s where their liver function tests, their transaminases are mildly elevated. People have been poo-pooing it for a while because they're not jaundiced and they otherwise feel well. Well, that mild inflammation is like rust on your car until your entire exhaust system goes out in your 50s and 60s. And increasingly, I certainly see people with advanced liver disease. It's one of the many tools that, again, crosses over. It turns out that most people with fatty livers don't die of liver disease. They have concurrent heart disease and kidney disease. So they wind up on dialysis, or they wind up having heart attacks and cardiac stents and things. But we've got a nice tool to look at it when it's in the preclinical, pre-symptomatic state, which is fabulous. And I think that's what we don't have really for EoE. We wind up finding it, but we're never sure exactly what the triggers are or why someone walked around feeling generally fine, eating, drinking, having a nice day, and all of a sudden they're in the ER with a foreign body in their esophagus.
So when that happens and it's related to EoE, it's because they have trouble swallowing because of the inflammation in their esophagus?
It's the inflammation itself, or it's because inflamed, the waxing and waning inflammation leaves scar tissue. So instead of having that nice peristaltic muscle going down, you have an area where it's stuck. It's like a clog in a drain.
And so that's why a lot of times people with EoE might have a lot of hiccups or something.
It's not so much hiccups. They feel food catch,
Okay.
or they'll actually show up in the ER saying, I was eating at this steakhouse and I felt fine until something didn't go down, and now I can't swallow, and they're drooling because they can't swallow.
But they can breathe. It's not
Yeah,
the air.
absolutely, they can.
Yeah.
breathe.
Does that have like Heimlich implications sometimes where it gets stuck, or is that higher up where?
No, the Heimlich thing is that it's covering your airway. So this is further down. The nice thing about the esophagus in humans anyway is that the upper third is smooth muscle, and is a skeletal muscle rather, and then the rest is smooth muscle. We tend to be pretty protected in that upper third of the esophagus, and it's that lower third, that lower 2/3.
So it's stuck further down.
Yeah, it's stuck further down, right about where your breastbone starts. People come in, they can speak. They're like, something's stuck. They're uncomfortable. It's very dysphoric. It's very uncomfortable to have food stuck. But the ER nurse is going to sit on them for a while and call one of us in to deal with that. They're not going into the trauma room or anything.
How do you get that out?
You sedate the person, you go down with the endoscope, and we have little baskets and tools to, depending on what's down there, to either grasp it or to capture it and take it.
So you're like a plumber.
I spent 32 years doing plumbing.
You sound like the guy who's always coming into my bathroom, that after a while, because with all the hair blowing and stuff that mom does, it's like,
Yeah, what's the water shut off? What are the water shut off equivalents that you have to do before you can get in there and?
Yeah, you have to make sure that people are breathing well and that they're sedatable, and that if that's dicey, then you have to intubate them, have anesthesia, intubate them, and protect their airway and do it. Most of the time, we don't need that. We can just gently sedate people, grab it, and get out. And
What's
tell
the
them,
biggest thing you fished out? Do you have any pictures of you like holding it, kind of like?
You have
you
no
went on
idea
a boat?
what people swallow and take out. Everyone says you could write a book, but I'm like, you tried to do what? Between what they put in the top and what they put in the bottom, you can write a.
well, how about those restaurants where they get these like weird foods that they eat and they fly them in? It'd be interesting if anybody gets it at one of those fancy New York restaurants where they're eating like weird animals and stuff.
Yeah, but most of the time it's just too big a bite. It's a big chunk of something.
I can't even imagine what we used to say when people did at the other ends. Can you imagine in the front end?
Yeah.
That
Well,
you had to take out back then too.
But to Dr. Epstein's point, that'd be a good coffee table book. The first half is the things we took out the throat, and the second half is the things we got out the back.
yeah. The problem with the bottom is that it's at least an R rating or an X rating for most of it.
Is that usually related to some sort of
Yes,
intestinal EoE, or
yes,
and
that's-
that
no,
and
that's
it
from
got
the
stuck
amorous-
because
that's
they had a
just
certain
amorous-
inflammation that
amorous
wasn't letting it go all the way out the mouth or something?
That's amorous activity, and that's it. That's all I want to say.
Oh, that's
about
really
that.
That's a nice word for it.
Yeah, well, I've worked hard to have something to dictate into the medical record.
So is Valentine's Day or February 13th, is that a big day for you?
No one. Wait,
sorry,
no
wait,
one
February
wanted to call on
15th.
that day, right?
Actually, Mother's Day is a big foreign body day at the top because people
Okay.
take out their moms to fancy restaurants and steakhouses, and they're usually eating, they're not given all this fancy chunks of food. So I've done my share of work on Mother's Day over the
But
years.
everybody, like you give the new grads the Valentine's Day, right?
Right.
So do you recommend people like, hey, maybe instead of a steakhouse, I think your mom would really like a smoothie shop or a soup restaurant just to make it
Yeah,
easier for everybody involved?
definitely. Or just make sure they cut their pieces up well.
I used to moonlight like a lot. People don't moonlight anymore, but because they have PAs and NPs. So I was the doc overnight on Fridays at University of Colorado Health Science, at the school. And so like Fridays and Saturdays, it's really not the day you wanted to be at. I used to sew up more hands. Every time a girl dumped a guy, he put his hand through glass. And I was like, why don't you just punch a pillow? It's like you're bleeding all over and you have me sewing you up at 1 a.m. It's like
Why don't you go to therapy?
Yeah, the 1980s were an interesting time in the ER.
yeah, it's just like, oh my God.
Speaking of what things were like in the past, we could go even further back. Dad, I don't know if you got a chance to read it yet.
I
but-
did.
Oh, good. Someone I went to college with who is a gastroenterology, hepatology fellow who at some point we might try to get on the show. I'm sure he's busy. I saw him share this article about the ancient gut microbiome and how these researchers were able to find 1,000-year-old preserved feces in caves in Utah and Mexico, and they were trying to use those to study the ancient human gut microbiome.
Just a quick question. Is there a problem when you warm it up?
It's not a matter of warming it up. You're dissolving it in a way to just
Okay.
get DNA. All that's
So
there
it
is,
doesn't stink or something when you warm it up. I mean, it's a lot
There's-
of poop.
No, and odor is
Okay.
odor is long gone. You're dealing with
Okay.
calcified fiber and DNA.
See how
And so you're
smart
just
he is, Drew?
extracting
He
the
knew
DNA.
it.
What's the
Yeah.
oldest poop you've had to deal with?
Yeah, I've never done anything like that. I think it's interesting to see for people who do this kind of work to say, well, what we're seeing is that these ancient societies had a much more diverse gut microbiome. So, I think that's an interesting topic. Now, it's not like those people were living to 100 years old and healthy. Things were killing. The average age of death was like in their late 20s to mid 30s, even into the 1700s.
And there was also that point about how, part of the gut diversity was the fact that they had no antibiotics back then.
Right. But there's no question that antibiotic overuse is a problem across our field, both in that it affects your own gut microbiome and your ability to diversify and recover, and but also just antibiotic resistance. So the fact that you have to realize antibiotics are fed to farm animals and other things. So it just makes resistant organisms across the whole world. But the field, the interesting thing is that all those gut bacteria make small molecules. A lot of those small molecules are processed by the gut into neurotransmitters. So, and then they're washed forward towards the liver and they're interacting with the vagus nerve and things. So I think one of the things that you'll see on future podcasts, for people that know more about this than I do, the vagus nerve, which is the big wandering nerve that covers the whole gut, is turning into a huge therapeutic area in the gut to treat things like Crohn's disease and ulcerative colitis, because the signaling that comes north from gut bacteria and other things is traveling up the vagus nerve, interacting with other areas of the immune system, and then traveling down and triggering inflammation. So we're just starting to scratch the surface of the gut vagus nerve immunology axis. And if I had another life, I'd probably want to study that.
We're all talking about it's great, this diversity of the microbiome. We don't have enough diversity of the microbiome. But, you're comparing to 1,000 years ago, or how many years ago is this? And maybe too much diversity isn't great either, because if it's not as diverse before we had antibiotics, who's saying that this microbiome group is the same as 200 years ago? And so the question is, maybe too much isn't good. The vagus nerve is all about the treatment for chronic cough.
We don't know how to optimize it, but what we do know is that societies that eat a lot of fermented foods, yogurts, kimchi, pickles and things that still have active cultures in them, tend to be healthier societies overall. So
I saw kimchi might even have the ability to bind to and flush out microplastics.
maybe, but
Yeah.
but
I'm not saying that's, it was a meme, so who knows?
Right. I'm not sure about that. If you asked me, when I tell patients not to necessarily buy over-the-counter probiotics, but to eat fermented foods, I'm saying those things work. The problem with the supplements is it's the Wild West out there. There's no control over whether it's Whole Foods or GNC or the vitamin store selling you stuff, and whether that really gets through in significant amounts through your stomach acid into your small bowel and then populates is different than steadily eating your diet with a natural buffer like yogurt or kefir on a regular basis and helping to maintain your gut microbiome. So this doc eats yogurt almost every day.
So as a GI doctor, how often are you getting Korean barbecue?
Not often enough, but that's just because I like it.
Anyway,
Yep.
this has been very interesting.
Yep.
Very interesting.
Yeah.
Yeah, interesting is we say that a lot on this show.
Your dad and I have been in this for more years than we would want to talk about. But then you say well, those are whole new areas that I really, if you gave me another lifetime, I'd really like to look into them because, EoE wasn't around when I was a fellow. And, people used to tease me when I would come home from being a GI fellow a little late, and my neighbors on my block would say "You're getting home late. Were you on call?" I said, "No, we had peptide club," and they were like, "Well, that sounds like the geekiest thing you could possibly be involved in," and I was like, "Yeah, maybe it is." But what we were looking at were a lot of the things, these incretins that the GLP-1 drugs activate their receptors. So we didn't know necessarily what a lot of these things that were made by the gut cells, how they interacted with the immune system were doing, but we were looking at them all, or starting to look at them all, and some people were doing, their theses and whatnot on them. But when I think back, I said, maybe I should have stayed with that. I might have, been like Drew Weissman, our classmate who won the Nobel Prize. Who knows?
So the GLP-1s, they're really playing a big role with inflammation. And I feel the environmental allergens are in certain patients with EoE are underlooked. But one thing that I'm always questioning is our sublingual immunotherapy. So I don't do shots, we do the drops because it's a safer, more focused, but then we won't put people with EoE on it. But are we really doing them a disservice if it's quickly reversible, if you stop it, if you're going to treat the inflammation? That's my question.
Yeah, I don't know. I don't know the answer to that. We have a variety of roles. One is we want to make people better. And you make people better. That's great. How did you make them better? How do you sustain it? When I see patients with bad fatty livers and I'm telling their internists who work with me, this is someone I'd like you to start on a GLP-1 type drug. The issue is what's going to happen to try to get them off it. If half the people are going to gain their weight back, well, the other half won't, and that's a success. But how do you sustain it? Do all those things. I think we're all walking this together. I'm looking at it and saying, when I'm, 10, 15 years down the road, I don't want X person to have cirrhosis of their liver. But cirrhosis isn't probably going to be the thing that kills them. It's going to be kidney disease and dialysis or cardiovascular disease and heart attacks. But, you know, at the same time, how are we going to sustain that after the initial weight loss? What's going to be our maintenance plan? How much will that be anti-inflammatory? I think it's fascinating to follow, but we're really doing the experiments on millions of people.
Right. And that's similar, which I bring up all the time, trying to go after the root cause. A lot of these medicines that are coming out are fantastic. They've made such a dramatic life change for patients, but they're treating the end game. And it's okay. What are the next steps? How do you get them off? What do you do? That is something we don't have much data on because it doesn't put more people on a drug, and so that's our whole way of treating medicine, is not always looking at it in the right big picture, in my opinion.
Or over time. And I think as we stay in our silos more and more, there'll be less of that to say, like, okay, my internist who works alongside me, that person and I can continue over months and years to interact and say, hey, so-and-so did great when they were on the GLP-1 drug. They came off it. They're gaining their weight back. Now maybe we want to restart it at a smaller dose. Those kind of interplays, I think, unfortunately, have become less and less.
And so many patients don't have a primary care, or it keeps changing, which only makes this more difficult.
And the primary care visits have been shrunk down where you can barely get through the problem list. So certainly if a problem starts to flash red, you almost don't want to look at it. If a patient comes in with 4 things in their problem list, and the 4th happens to be fatty liver and mildly elevated transaminases, that might fall to a place where it's never dealt with, because the top 3 were, I have terrible heartburn and I can't sleep at night, or this or that, or whatever they're dealing with. So that's why I wind up seeing a lot of people who've got late problems, because the thing that I'm dealing with was always in the problem list. It just never made it to the top 3. And in a 15, 20-minute visit, how many things can you really deal with? I have the luxury of usually seeing 1 or 2 problems in a 20-minute visit. Okay, that's somewhat tolerable, and I can see people back. But I think you would like to encourage some of your best people to stay in internal medicine, and certainly the rise of concierge type medicine. The rise of that is people who can afford it want doctors to do more than spend 10 minutes with them. They want 30 to 40 minutes with people who care about all aspects of their care.
And all of us are seeing it. We're all seeing patients with so many I used to see plain allergies, and now it takes 15 minutes to get through their meds, just to, even for me, to get their list of meds. It's different, and it's time consuming, and it's hard to do it the way it is.
We would all like to roll it back before there was pharmacy benefit managers, prior authorization, RVUs, 15-minute visits. There was really, at least for your dad and I, a kinder, gentler time in medicine where you could look forward to seeing someone because it was a great case. You wouldn't dread a great case because you'll be like, this is a great case, but it's going to consume my whole day. That kind of thing.
Well, I think this is typical of our show. We start in something very specific, and then we realize how it's a microcosm or a symptom of a much larger interconnected system, either in the body or in the healthcare industry. Well, thank you, listeners, for checking out the show. I hope you enjoyed this conversation as much as I did. If you're enjoying these conversations, subscribe so you don't miss new episodes. It also helps more people find the show, which we really appreciate. Again, follow the link in our description to send us your question. You can email us to myallergistdad@gmail.com, and we'll answer your questions on the show. Before we go, Dr. Epstein, Dr. Z, any final thoughts?
only that it was a pleasure being here today and to talk, to see your dad and just meet you and to talk about topics. That I
Alan, it
happen
was
to
great
love.
having you, and I love it that it was thought-provoking, and I hope our listeners will enjoy it too.
Yeah, and if they have questions, they can get back to you and I, and we'll see if we can answer them.
Sounds good. Thank you so much for your time, and take care.
Bye,
Okay,
Alan.
thank you, guys.
If allergies got you down bad, then just ask my allergist, My Allergist Dad.
The My Allergist Dad podcast is for general informational and entertainment purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice, and no doctor-patient relationship is formed. The use of information on this podcast or materials linked from this podcast is at the user's own risk. The content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice for any medical condition they may have and should seek the assistance of their healthcare professionals for any such conditions.